Welcome to the deep dive. Today we're doing something a bit different. We're taking you, our future medical professionals, on a journey, almost like a time machine trip. Picture this. You're in Los Angeles, it's June 1981. You and your team are doing rounds, and you start seeing these really unusual cases. Young men, healthy, just weeks before, now presenting with identical, truly devastating symptoms. Things like a rare lung infection, pneumocystis pneumonia, PCP we call it now, and this aggressive skin cancer that just seems to pop up out of nowhere. It's perplexing, right? Soon, you hear whispers, then reports. Other hospitals are seeing similar things. It's spreading. Then, June 5th, 1981, the CDC publishes this critical report in their Morbidity and Mortality Weekly Report. It wasn't just another bulletin. It was like a FNAR going up in the dark, signaling something completely new and, frankly, terrifying, a real turning point. Now, before we dive deep into what this mystery was, here's a quick question for you listening. Can you recall the clinical term for that aggressive skin cancer we mentioned, the one seen so often in those early cases? Keep that in the back of your mind. We'll definitely circle back to the answer later on.
That really sets the scene, doesn't it? Captures that sense of urgency and confusion. So today, we're digging into the Human Immunodeficiency Virus, HIV, and its most advanced stage, Acquired Immunodeficiency Syndrome, or AIDS. Our goal here, especially for you as maybe a first-year med student, is not just to understand this stuff, but to really retain it so you can recall it easily. The aim is to equip you to handle complex patient scenarios with both the knowledge and real compassion. This stuff impacts real lives profoundly.
Absolutely. So let's start with something fundamental because it trips people up sometimes. What exactly is the difference between HIV and AIDS? Are they the same thing or is there a clear line?
That's a great starting point. And yeah, it's crucial to get it right. Think of it this way. HIV is the virus. It's the actual invader, the Human Immunodeficiency Virus. Its whole mission, if you like, is to find and attack specific cells in your immune system. AIDS, on the other hand, Acquired Immunodeficiency Syndrome, that's the result. It's the most advanced stage you get if HIV infection isn't treated. It signifies that the invader, HIV, has basically won too many battles. The immune system is severely compromised, leaving the body vulnerable. So HIV is the cause, AIDS is the late-stage consequence.
Okay, invader versus result. That clarifies it nicely. So let's get to know this invader better, HIV. It's part of the retroviridae family, right? HIV-1 and HIV-2, what does it actually look like structurally? What makes it so effective at attacking our cells?
Exactly, it's a retrovirus. And structurally, it's pretty sophisticated for its size. Imagine a tiny sphere. On the outside, it has this enveloped membrane, sort of like a stolen coat it takes from our own cells when it buds off. Sticking out from that coat are these crucial surface glycoproteins. You'll hear about GP120 and GP41. Think of those as the virus's keys. They're specifically designed to fit locks on our host cells. Inside that envelope, there's a protein shell, the capsid, made of the P24 protein. And inside that are the important bits, 2 single strands of RNA, the virus's genetic material, plus essential enzymes like reverse transcriptase, integrase, and protease. It needs all those to replicate. And it's worth quickly distinguishing HIV-1 from HIV-2. They're different. HIV-1 is the one that caused the global pandemic. It's everywhere. It spreads more easily through heterosexual contact and from mother to child. That's vertical transmission. Untreated, it usually progresses to AIDS in, say, around 9.8 years on average. HIV-2 is mostly found in West Africa, much less common elsewhere. Its transmission rates are lower, about 5 times lower for heterosexual spread, and maybe 20 to 30 times lower for vertical transmission. Plus, people with HIV-2 tend to stay asymptomatic for much longer, maybe 10 to 25 years. So different behavior, different outcomes.
Right, so those viral keys, the glycoproteins, are looking for very specific locks on our immune cells. Which cells are HIV's main targets? What makes losing them so devastating for our immune system?
The primary target, the absolute key player HIV goes after, are the CD4 plus T-cells. We often call them helper T-cells, or even the generals of the immune army. They're crucial because they coordinate so much of the immune response. They don't just fight infections themselves, they tell other immune cells what to do. So when HIV takes out these generals, the whole defense system starts to crumble. That's why people become vulnerable to very specific kinds of infections, those opportunistic ones we'll get to. Yeah, their job description is huge. They boost B cells to make better, longer-lasting antibodies. They help CD8 plus T cells, the killer cells, expand and form memory. They release cytokines, which are like chemical messengers to call in macrophages. And critically, they're essential for cell-mediated immunity. That means activating cells to fight pathogens hiding inside our own cells, things like viruses or certain bacteria, and also dealing with cancerous cells. Losing CD4 cells is catastrophic. And it's worth mentioning, too, that other cells, like macrophages and dendritic cells, can also get infected and act as reservoirs for the virus, helping it hide and replicate.
Okay, Generals of the immune army. That's a powerful image. So we know what it is, who it attacks, but how does it do it? How does HIV actually get inside those cells and start reproducing? Let's unpack that viral battle plan.
Right, the replication cycle. It's a fascinating, if destructive, process. We can break it down into 7 key steps. Think of it like a factory assembly line for making new viruses. 1. Binding. That GP120 key on the virus surface locks onto the CD4 receptor on the T cell, but it also needs to bind to a co-receptor, usually CCR5 or CXCR4, on the same cell. It needs both to get in.
Like a double lock system.
Exactly. 2. Fusion. Once it's securely attached, the virus's envelope fuses with the cell membrane, basically merging with it, and dumps its contents, the capsid, with the RNA and enzymes inside the cell.
Okay, it's in. Then what?
Step 3, reverse transcription. This is the hallmark of a retrovirus. It uses this enzyme, reverse transcriptase, to convert its RNA genome into DNA. This is backwards from how our cells normally work, DNA to RNA. That unique step makes it a great target for drugs.
Hence the name retrovirus. Makes sense.
Precisely. 4, integration. The newly made viral DNA travels into the host cell's nucleus. Then, another viral enzyme, integrase, cuts the host DNA and pastes the viral DNA right into our own genome. Now that cell is permanently infected. It's become part of the virus factory.
Wow, okay, so the cell's own machinery gets hijacked.
That's step 5, replication. The cell now treats the viral DNA like its own, transcribing it into viral RNA and translating it into viral proteins. It's basically forced to mass-produce virus parts. 6, assembly. All these new viral RNA strands and proteins gather near the cell surface. They start putting themselves together into new immature virus particles. And finally, 7, budding. The newly assembled particles push out from the cell surface, wrapping themselves in a piece of the host cell membrane to form their own envelope. As they bud off, or shortly after, another enzyme, protease, cuts long viral proteins into their final functional forms, making the new virus mature and ready to infect other cells. And the cycle starts again.
A 7-step invasion. It sounds incredibly efficient. Now, we understand the internal mechanics, but how does HIV actually get from one person to another? What are the main transmission routes we need to know?
Right. Transmission relies on contact with specific bodily fluid that contain enough virus.
Yeah.
We're talking about blood, semen, pre-seminal fluid, rectal fluids, vaginal fluids, and breast milk. So the primary routes are sexual transmission. This is the most common way. Anal sex carries the highest risk, followed by vaginal sex. Oral sex risk is generally considered minimal, but not zero.
Okay, what else?
Mother-to-child transmission, or vertical transmission.
Yep.
This can happen during pregnancy, labor and delivery, or through breastfeeding. But, and this is critical, interventions like RD for the mother can cut this risk dramatically, from maybe 30% down to less than 1%. Huge success story there.
That's incredible, less than 1%.
Yeah. Then there's injecting drug use. Sharing needles, syringes, or even cookers or cottons used to prepare drugs. That's direct blood-to-blood contact. And HIV can actually survive in a used syringe for quite a while, up to 42 days potentially. We often use the term PWID, people who inject drugs. Also, blood products or organ transfusions. This was a major route early on, but with modern screening in most developed countries, the risk now is extremely low, a real public health triumph. And lastly, there's occupational risk, like needle stick injuries for healthcare workers. Though again, protocols make this much less common now.
Got it. So those are the ways it can spread. But just as important, especially for tackling stigma, is what doesn't transmit HIV. Can we run through those common myths?
Absolutely vital. HIV is not spread through casual, everyday contacts. You cannot get it from spitting, kissing, like social kissing, biting, unless there's significant blood involved, which is rare, touching someone's unbroken skin, sneezing, or coughing. You also can't get it from sharing baths, towels, or cutlery, using the same toilets as swimming pools, giving mouth-to-mouth resuscitation, or from animals or insects like mosquitoes. Mosquitoes transmit malaria, West Nile, but definitely not HIV.
That clarity is so important. Okay, we've covered the risks, the myths, but now let's get to something truly transformative in the world of HIV. This is where modern medicine has just been incredible.
Yes, this is probably one of the most important public health messages about HIV today. It's the concept summed up as undetectable, untransmissible, or UU. What this means, backed by massive studies, is that people living with HIV who are on effective antiretroviral therapy, RT, and maintain an undetectable viral load, meaning the amount of virus in their blood is too low to be measured by standard tests, usually for at least 6 months, do not transmit HIV to their sexual partners.
Let me just repeat that because it's so powerful. Undetectable means untransmissible through sex.
Exactly. Zero risk. It has revolutionized prevention, reduced stigma, and allowed people with HIV to have relationships without fear of transmission. And just to circle back, this is why fluids like saliva, sweat, tears, urine don't transmit as accidents. The viral load isn't high enough, even in untreated individuals, let alone those who are undetectable.
Game-changing. So let's apply UU to a clinical scenario you might encounter. A 32-year-old man, HIV positive, comes to your clinic. He's been on our undetectable viral load for 18 months straight. He asks about the risk of transmitting HIV to his HIV-negative partner if they have sex without a condom. What's the accurate advice here?
Based firmly on the UU evidence, the most accurate statement is that because he has maintained an undetectable viral load on RT for well over 6 months, he will not transmit HIV to a sexual partner. RT is doing two jobs here, keeping him healthy and preventing transmission. While condoms are great for preventing other STIs and are an option, they aren't necessary to prevent HIV transmission in this specific UU context.
Fantastic. Clear, evidence-based advice. Now let's shift focus to the clinical journey itself. If someone does get infected and isn't treated, how does the disease typically progress? What are the stages?
Okay, so without treatment, HIV infection generally follows 3 stages. Stage 1 is primary HIV infection or acute seroconversion. This usually happens 2 to 4 weeks after exposure. People often get a flu-like or mono-like illness, fever, sore throat, maybe a rash, maculopapular, feeling unwell, headache, muscle aches. Importantly, viral load is extremely high during this stage, so people are very infectious. Sometimes, less commonly, you might see neurological things like meningitis.
So in acute phase, then it settles down.
Yes, into stage 2. Asymptomatic HIV infection, sometimes called clinical latency. This phase can last for years, often a decade or more. People might feel completely fine or have only mild symptoms, but silently, the virus is still active, replicating at a lower level, and the CD4 T-cell count is gradually declining. The immune system is slowly being weakened, even without obvious symptoms.
And the final stage.
Stage 3 is Acquired Immunodeficiency Syndrome, AIDS. This is the most severe phase. It's crucial to remember, though, with today's treatments, progression to AIDS is not inevitable. Many people with HIV never develop AIDS. AIDS is diagnosed based on 2 main criteria. Either the CD4 T-cell count drops below a critical level, 200 cells per cubic millimeter of blood, or the person develops 1 or more specific severe opportunistic infections or cancers.
Okay, those opportunistic infections, they really define AIDS, don't they? This is when the immune system, lacking its CD4 generals, just can't fight off things that wouldn't normally cause problems.
Exactly. We sometimes call them indicator conditions. Seeing one of these should make you immediately think about testing for HIV because they're either formally AIDS-defining or just very strongly associated with underlying immunosuppression, often from undiagnosed HIV.
So what are some key examples of AIDS-defining illnesses?
Well, top of the list, especially historically, is Pneumocystis pneumonia, PCP, caused by a fungus. Pneumocystis jirovecii causes severe shortness of breath, a dry cough, low oxygen. Very rare in healthy people. This was one of those first signals back in 1981.
Right, from our intro case.
Yep. And the other big one from the early days, the answer to your earlier question, is Kaposi sarcoma, KS. This cancer is caused by human herpes virus type 8, HHV8. It causes those distinctive purple lesions on the skin, mouth, sometimes internal organs. Seeing KS in a young person was and is a major red flag for underlying immune deficiency, usually HIV.
Kaposi sarcoma. Got it. What else falls into that AIDS-defining category?
Others include CNS cryptococcosis, a fungal meningitis caused by Cryptococcus neoformans, presence with headache, fever, maybe seizures, usually seen when CD4 counts are really low, often below 100. Also things like esophageal candidiasis, severe thrush in the esophagus, cerebral coxoplasmosis, a brain infection, disseminated histoplasmosis, another fungal infection common in some parts of the U.S., visceral leishmaniasis, and severe HIV wasting syndrome. These are serious life-threatening conditions when the immune system is that damaged. And then there are conditions that aren't strictly AIDS-defining, but have a high association with undiagnosed HIV, like severe shingles, certain types of lymphoma, persistent seborrheic dermatitis, having hepatitis B or C, or significant unexplained weight loss. Seeing these should also prompt consideration of an HIV test.
That's a sobering list. And briefly, does it look different in infants and children?
It can, yes. Common presentations include failure to thrive, recurrent severe infections like pneumonia or diarrhea, PCP, CMV disease, developmental delays, HIV encephalopathy, swollen parotid glands, widespread lymph node swelling, or things like shingles, which are unusual in young kids.
Okay. Given all these possibilities, how do we actually confirm an HIV diagnosis? What are the standard tests we use?
The testing technology has advanced a lot. The mainstay now is the antigen antibody test, often called a fourth-generation test. It's great because it detects two things: antibodies produced by the body against HIV, IgM and IgG, and the P24 antigen, which is part of the virus itself, the capsid protein. The P24 appears earlier than antibodies, so these tests can detect infection sooner.
So fourth-gen tests are the go-to screening.
Generally, yes. There are also older antibody-only tests, still used sometimes. And for specific situations, like testing newborns of HIV-positive mothers, where maternal antibodies can interfere, we use RNA-DNA tests, or NATs, which directly detect the virus's genetic material. And crucially, any positive screening test always needs confirmatory testing, usually with a different type of test, to be absolutely certain before giving a diagnosis.
You mentioned the P24 antigen allows earlier detection. That brings us to the window period. Can you explain what that is and why it's so important clinically?
Yes, the window period is critical. It's the time between when someone is exposed to HIV and when a test can accurately detect the infection. During this period, the virus is replicating, but the body hasn't produced enough antibodies, or there isn't enough P24 antigen yet, for the test to pick it up. So testing too early can lead to a false negative result.
How long is the window period typically?
With the older antibody-only tests, it could be up to 12 weeks, sometimes longer. But with the fourth-generation antigen tests, it's significantly shorter. P24 antigen is usually detectable within about 2-3 weeks, and antibodies around 4-6 weeks. So these newer tests close that window considerably, but there's still a period right after exposure where no test will be positive.
Right. Let's test that understanding. A 28-year-old woman comes in just 48 hours after a needle stick injury involving blood from a known HIV-positive patient. She's anxious and wants an HIV test immediately. What do you advise?
Okay, classic scenario. At 48 hours, it's definitely too early for any standard HIV test to be reliable. It's well within the window period. So the advice is that immediate testing won't rule out infection. You'd explain the window period and recommend follow-up testing, usually around 2 weeks, and again at 6 weeks post-exposure with a fourth-gen test. But critically, the immediate priority at that 48-hour visit isn't testing, it's discussing and, if appropriate, starting PP post-exposure prophylaxis.
PEP, right. We'll come back to that. So beyond specific exposures, when should we be offering routine HIV tests in, say, primary care?
Good question. Guidelines generally recommend offering testing in several situations. To all adults when they register with a new GP or if they're admitted to a general medical ward, especially in areas with higher HIV prevalence, like over 2 per 1,000 people diagnosed. Obviously, if a patient asks for a test. If someone has known risk factors, for example, being a man who has sex with men, MSM, a person who injects drugs, PWID, someone involved in the sex industry, or having a partner from a country with high HIV rates. If they're diagnosed with another STI because the risks often overlap. And definitely if they present with symptoms suggestive of acute HIV infection or any of those indicator conditions we discussed earlier, things like PCP or cryptococcal meningitis need urgent investigation and often hospital admission.
Are there still barriers to people getting tested?
Unfortunately, yes. Things like difficulty accessing services, sometimes lack of awareness or knowledge among clinicians, patient fear or stigma about a positive result, and sometimes cost, though testing is often free. But things are improving, especially with the rise of self-testing kits, which offer more privacy and convenience.
Okay, so we know how to diagnose it, when to test. Let's talk prevention and management. With you in modern medicine, what are our best strategies now?
We have a really strong toolkit now for both prevention and management. For prevention, condoms are still effective, especially for preventing multiple STIs, not just HIV. Testing is key, knowing your own status and encouraging partners to know theirs. For PWID, access to sterile, single-use syringes and needles through needle exchange programs is vital. Then there's PAP, or pre-exposure prophylaxis. This involves HIV-negative people at high risk taking daily antiretroviral medication, usually a pill like tenofovir alafenamide. It's highly effective, reducing sexual acquisition risk by around 86% or even more if taken consistently. Requires regular HIV STI screening, usually every 3 months.
Pre-TP has been a huge development. What about after a potential exposure?
That's where PEP, post-exposure prophylaxis, comes in. This is a 28-day course of combination ART-T taken after a potential high-risk exposure like that needle stick injury or condomless sex with someone of unknown or positive status who isn't undetectable. It needs to be started ASAP, ideally within 24 hours and definitely within 72 hours to have the best chance of working. Then you do follow-up HIV testing. And finally, screening programs, especially routine screening in pregnancy, have been incredibly successful, particularly in virtually eliminating mother-to-child transmission in many countries.
So, a multi-pronged prevention approach. Now, what happens when someone is diagnosed? What does management look like today?
The cornerstone of management is Antiretroviral Therapy, RT. As soon as possible after diagnosis, individuals are typically started on a combination of ART drugs. The goal of ART is twofold. First, to suppress the virus, ideally to undetectable levels, which keeps the person healthy and prevents disease progression. Second, as we know from Hugo, becoming undetectable also prevents transmission to others. It's crucial to understand ART controls the virus, it doesn't cure it. HIV integrates into the host DNA, creating a latent reservoir that current drugs can't eliminate. So, RT is lifelong therapy.
And RT isn't just one drug, right? It's usually a combination.
Exactly. Using a combination of drugs that attack the virus at different points in its replication cycle is much more effective and helps prevent the virus from developing resistance. We have 5 main classes of these drugs, targeting different steps in that factory assembly line we discussed. NRTIs, nucleoside-tied reverse transcriptase inhibitors, and NNRTIs, non-nucleoside reverse transcriptase inhibitors, both block reverse transcription, step 3. PIs, protease inhibitors, mess up assembly and budding, steps 6 and 7, by stopping protease from maturing the new virus particles. 2. Integrase inhibitors, block integration, step 4, preventing the viral DNA from getting into the host genome. These are very commonly used now. And EIs, entry inhibitors, block binding and fusion, steps 1 and 2, stopping the virus from getting into the cell in the first place.
So you hit the virus from multiple angles. What does long-term care involve?
Long-term care is about regular monitoring and support. We monitor the CD4 count to ensure the immune system is strong or recovering. We monitor the viral load using PCR tests to make sure it stays undetectable. We also screen for and manage opportunistic infections, sometimes using prophylactic antibiotics or vaccines if the CD4 count is low. And we manage other health issues, as people with HIV are living longer lives. If the viral load starts to increase on treatment, it usually means the virus has developed drug resistance. So we do resistance testing and adjust the RT regimen accordingly.
It sounds like a very manageable chronic condition now, which is incredible progress. So bringing this all together, what's the key takeaway for you, the future doctor, listening to this?
I think it's understanding that HIV isn't just a virus. It's a story about science, society, stigma, and resilience. The early days were marked by fear and misinformation, which had devastating impacts. It taught us, or should have taught us, the vital importance of combining scientific rigor with deep compassion when facing any health crisis, especially one tangled up with social prejudice. You'll see echoes of this in how we handle other epidemics, too.
But looking ahead, the landscape continues to change, doesn't it?
Absolutely. People with HIV are living much longer now, into old age, which is fantastic. But it brings new challenges managing aging-related conditions alongside HIV. There's also a need for more equity. Early ART trials often didn't include enough older adults, women, or people from diverse backgrounds, so we're still learning about potential long-term side effects or drug interactions in these groups. Your generation of doctors will be key in addressing those health disparities.
It's a field that keeps evolving. So a final thought for our listeners. As you start your medical journey, think about how many other mystery cases or hidden diseases might still be out there. Maybe they don't look like the 1981 scenario, but they're waiting for curious, compassionate minds like yours to connect the dots, challenge assumptions, maybe question dogma. What role will you play in solving the next medical mystery?